A very good evening to all of you on behalf of Neurocritical Care Society of India and Classroom Series. We have today with us the CMC Vellore team who will be presenting the Journal Club. It will be presented by Dr. Sri Kumar, who is a senior resident DM Neuroanesthesia in the Department of Neuroanesthesia, and it will be moderated by Dr. Keta. Over to you, ma'am.
Uh, a very good evening to everyone, and thank you for joining. Today we are here to present this systematic review and meta-analysis of on early seizure prophylaxis in mild and moderate traumatic brain injury. Seizure prophylaxis after traumatic brain injury have always been a topic of debate, and whether it can or should be given after mild and moderate traumatic brain injury is yet to be determined. We are going to present this, which was this article was published in JAMA Neurology recently on April 2024. So Dr. Sri Kumar, who's a first year senior resident in DM Neuroanesthesia here at CMC Vellore, will do the presentation and will take us through the whole methodology as well as the results and the discussion section, followed by which I will do a critical appraisal for the same. Over to you, Sri Kumar.
Thank you, madam. First of all, good evening, everyone, for all the participants. Today, we'll be going through in detail a journal which was a systematic review and meta-analysis. So the topic of the journal is early seizure prophylaxis in mild and moderate traumatic brain injury. It was a systematic review and meta-analysis which was published in JAMA Neurology on April 8, 2024. So this study was conducted by Matthew Pease et al. From the Indiana University School of Medicine, Indianapolis, USA. So first of all, let's have a basic introduction to our topic. So traumatic brain injury is one of the leading causes of death and disability worldwide. So apart from the other symptomatologies of traumatic brain injury, one of the main symptomatology is the post-traumatic seizure. So why it is important is that it's a major contributor to a secondary brain damage after traumatic brain injury, and it leads to increased hospital length of stay, increased mortality, and worse functional outcomes. So basically, post-traumatic seizures can be divided into early and late. Early are which occur within 7 days of the trauma, and late which occurs after 7 days of trauma. One entity called immediate post-traumatic seizure is seizures which occur within 24 hours of trauma. So that's IPTS. So considering traumatic brain injury worldwide, about 82.3% are in the mild category and 10.8% are in the moderate category. So this statistics is very important because for the study, we'll be, as we go through the study, this statistic part is very important. So mild will be almost 80% of all the traumatic brain injuries. Post-traumatic seizures occur in 15% or more of patients with severe TBI. As we all know, it's a known fact, and this post-traumatic seizure incidents come to less than 5% if the patients are given seizure prophylaxis. So here we can see a significant difference. So what about the other category? What about the mild and moderate TBI? Whether seizure prophylaxis is needed or not? This is the area which is covered in this journal. This is the gray area. So the rates of early post-traumatic seizure in mild and moderate traumatic brain injuries 1 to 4% in the reported literature. But as we have already seen, most of the traumatic brain injury comes within this category of mild to moderate traumatic brain injury. So even if the incidence of seizure is 1 to 4%, that itself is a clinically significant amount. So here comes the relevance of the study. So what are the risk factors for an early post-traumatic seizure? So GCS less than 10, any brain contusion, any depressed fracture, any associated SDH, EDH, ICH, any penetrating injury, need for surgery, infants, amnesia lasting more than 30 minutes, any history of chronic alcoholism, and immediate post-traumatic seizure. That is within 24 hours of injury, if the patient had a seizure, that means he is at high risk of early post-traumatic seizure. Early post-traumatic seizure, always remember, it's within the 7 days. So, a brief idea about the pathophysiology of post-traumatic seizure. What happens is that there's an altered vessel regulation of the local cerebral blood flow, and there's an alteration of the hepatic encephalic barrier. That means a blood-brain barrier. So, increase in intracranial pressure with focal or diffuse presence of ischemic, hemorrhagic, inflammatory, or necrotic damage. So, these are the major contributors which leads to seizure. So in animal models, post-traumatic epilepsy or post-traumatic seizure was suggested by two main pathogenic pathways. One is an oxidative stress mechanism, and other is the excitotoxic mechanism, which lead to neuronal hyperexcitability. So two mechanisms contribute towards the post-traumatic seizure. So now let's see why the study is important. The effectiveness of seizure prophylaxis in mild to moderate TBI is unknown. So in an unknown, this is an unknown thing, but still most of the mild and moderate TBI receive seizure prophylaxis. And in some people, what happens is that even after the 7-day prophylaxis window is over, the treatment is continued. So there is no significant evidence for continuing this. And also the medications that these patients receive also show significant variation. No major guidelines exist in this particular group, that is mild and moderate injury. There are a number of systematic reviews for severe traumatic brain injury, but for the mild and moderate group, there doesn't exist any major guidelines. So this also reflects a lack of high quality studies evaluating the effectiveness of seizure prophylaxis for this group. So this is the study question they went about with. Is seizure prophylaxis associated with reduced risk for early post-traumatic seizures for patients with mild or moderate traumatic brain injury? So this is the base question, whether this seizure prophylaxis will help in these people. So with this base question, they went forward with the study. And the primary objective was to determine the association between seizure prophylaxis and risk reduction for early post-traumatic seizure in mild and moderate traumatic brain injury. The secondary objective was a subgroup analysis which included only the mild traumatic brain injury group, while the primary objective included both the mild and moderate TBI. And systematic review and meta-analysis was done using accepted evidence-based techniques and followed the PRISMA reporting guidelines, and the protocol was registered with Prosper. So this also is an important factor when we analyze the journal later. So it was already registered with Prosper. So then after they fixed their objective, they started the search. So what was the goal of the search strategy? So the goal was to find studies that compared the effectiveness of seizure prophylaxis for early post-traumatic seizure with those who did not receive seizure prophylaxis. So the studies should always have a comparison, that those studies only could be included in this meta-analysis. So what they did, they went to PubMed, Google Scholar, and Web of Science and for the search, and only articles published in English were searched, and from a time period of January 1st, 1990 through April 18, 2023. So the major search terms used were traumatic brain injury, post-traumatic seizure, post-traumatic epilepsy, trauma and anticonvulsants, and prophylactic anticonvulsants. Two investigators independently screened all titles and abstract, and the final included studies were investigated by 3 investigators. And these investigators were blinded to the final inclusion. So the inclusion criteria were studies that compared the seizure prophylaxis in early post-traumatic seizure to a control group after mild or moderate TBI. So only, as I have already said, the comparison studies with seizure prophylaxis and without seizure prophylaxis were included. And also studies which provided early seizure prophylaxis only were included. That means anti-seizure medication after an event of TBI within 7 days they should have given a seizure prophylaxis. Only those studies were included. Exclusion criteria were age younger than 18 years, no comparator control group without prophylaxis. Then those studies which stratified TBI based on alternative severity scale. Then failure to report the rates of early post-traumatic seizure within 7 days, and patients with existing seizure disorders. All those were excluded. And World Bank designated low or middle income countries, studies from these countries were also excluded to prevent heterogeneity. So, from the selected studies, the quality of each study were assessed using the Newcastle Ottawa scale. This is a easy to use Cochrane recognized quality checklist. So this NOS scale contains 8 items which are categorized into 3 domains. And in this study, injury severity was the most important factor. Additional important factors included age, mechanism of injury, and additional injury. And follow-up adequacy was assessed for only studies with 70% follow-up were included in the study. So if only 70% follow-up is there, then this study was considered as a good quality. Then the study was semi-quantitatively also assessed based on a star scale system, which included 9-star system. So the risk of bias was graded using the threshold for converting the NOS rating to an Agency for Healthcare Research and Quality, that's AHRQ standards. So they divided each studies into good quality, that's 7 to 9 points, fair quality 5 to 7 points, and poor quality less than 5 points. So the Newcastle Ottawa scale was assessed by 2 independent reviewers for each study.
Any problem, Srikumar?
Yeah, there's a small
Wow,
action.
okay.
Yes, that. Can you hear me now?
Yes, you're audible.
Okay. So moving on to the statistical analysis. So in the study, what they went forward is absolute risk reduction. So which included 95% of confident interval, and the significant was defined as a two-sided p-value less than 0.05. And a subgroup analysis was done in a group of only mild traumatic brain injury. In between study heterogeneity was assessed using I-square and Cochrane Q test, and publication bias was assessed using funnel plots. So let's see a few terms. What is relative risk reduction? It refers to a percentage decrease in risk achieved by the group receiving the intervention versus the group that did not receive the intervention. So that's the control group. So usually most of the studies goes for a relative risk reduction for most of studies. But why this study chose an absolute risk reduction is that the number we have already seen the percentage of post-traumatic seizure that occurs within the mild to moderate group is about 1 to 4% of all the studies that was included. An absolute risk reduction gives more significance in this case. And another important term is the number needed to treat. What this means is that the number of people who needed to be treated to prevent one undesirable outcome. So we'll see regarding these terms later. First, let's see the Prisma flow diagram of the study. 896 records were identified through database searching, and of the 896 title screen, 704 were excluded during the title screening itself. And of the 192 abstract screen, 128 were excluded because it did not satisfy the inclusion criteria mainly. So 64 full text articles were assessed for eligibility, and of this 56 were excluded because most of it were either book chapters or the GCS data were not properly available, or it included severe TBI. So finally, only 8 studies were included which satisfy the primary outcome measure, that's mild and moderate TBI. And of these 8 studies, 3 were excluded because it did not report the mild category separately. So only 5 studies were included for the secondary outcome. So 8 studies for the primary outcome measure and 5 studies for the secondary outcome measure. Moving on to the results, these were the 8 studies that were included for the primary outcome measures. And we can see two main important things in this. That one is that the type of study, where 6 of the studies were retrospective study and only 2 were prospective studies. And in the other box, which is marked in red, we can see that of this one study did not include the mild group at all. That is the Faropoulos study. That's a 4th study. That was excluded from the mild group. And the Dijon study also did not separate the mild and moderate group. They took mild and moderate group as a single group. So that also was excluded for the subgroup analysis. And the Pingu et al., that's the next group, mainly had moderate TBI patients. So that was also excluded from the mild cat. So these 3 studies were excluded, and all the other 5 studies were included for the subgroup analysis of mild TBI. Moving on to the evidence grading. Here we can see that all the 8 included studies were of the good quality, that is 7 points or above. So the reason of decreased quality in each of the studies were that only some of the studies only included patients at rehabilitation hospitals, and some they didn't provide adequate follow-up information, and those patients which were lost to follow-up, they didn't have a proper description of these patients. So all these led to a decrease in quality of some of the studies, but all the 8 studies were in the good quality range. So of the 8 studies, it had 5,637 patients, of which 1,541 received the seizure prophylaxis. And among the seizure prophylaxis, most were given levetiracetam or phenytoin. 3 of the studies used only levetiracetam for prophylaxis. And comparing studies, there was a wide range of average age, that is 33 to 65 years, and wide range of radiographic injuries and mechanism of injuries. And another important noted factor was that most of the patients were male. So moving further into the analysis, these are the 8 listed studies with their absolute risk reduction and 95% of confidence interval. That's a table. And below we can see the forest plot of the same data. And what was found that the absolute risk reduction with patients given prophylaxis in early post-traumatic seizure was 0.6%, with a 95% confidence interval of which showed values of 0.1% to 1.2%, p-value of 0.02. So the rates of early post-traumatic seizure in these studies range from 0 to 4%. So this is what I already discussed. The number needed to treat to prevent one seizure was 167 patients. This is actually quite significantly high. And the next analyzed factor was there was little heterogeneity between the studies with a negative Cochrane Q test and I-square value of 4%. So these were the analyzed results from the primary outcome study. So next is a shows a funnel plot. So what does a funnel plot gives us? It shows us whether there's a publication bias. So we can see that 7 of the 8 studies lie within the funnel plot, and only one which lies outside. This was a study which showed the negative effect of seizure prophylaxis. So, um, and this study was conducted at level 2 trauma centers. All other studies were conducted at level 1 trauma centers. So, this is the only study which lies outside the funnel plot, which shows that there is minimal risk of publication bias in this study. Moving on to the subgroup analysis. So when only the 5 studies which included mild TBI were analyzed, again we can see the absolute risk reduction of 0.6 with 95% confidence interval, 0.01 to 1.2 percentage, p-value of 0.04. Again, there was a minimal amount of heterogeneity within the studies, and the funnel plot again shows that all the 5 studies were within the funnel plot area, which shows there was no publication bias. Moving on to the discussion. So what we can infer from all these results is that all the study showed a modest but clear trend towards the benefit of seizure prophylaxis. And the results also showed a modest effectiveness of seizure prophylaxis. So, but the absolute risk reduction value was very small. That's only 0.6. Number to treat was 1 for 167 patients. So this shows that the statistical significance of absolute risk reduction is very less for the study because in comparison, seizure prophylaxis reduced the risk in severe brain injury by almost 11%, and in the mild to moderate group only by 0.6%. But why this 0.6% is important is that of its importance in clinical significance, because early seizure leads to longer hospitalization, non-home discharge, prolonged use of anti-seizure medication, unnecessary advanced diagnostic testing, work restrictions. So as seizure prophylaxis in these patients and prevention of seizure improves the functional outcome and quality of life in critically ill patients. So what happens that we have already seen the mild and moderate group made up almost 90% of the traumatic brain injury, and 0.6% risk reduction in this large group shows it's clinically significant, even though the statistical significance is comparatively less. And on the other hand, what about if we other effects of the anti-seizure medications? So older anti-seizure medications produce hyponatremia, memory problems, and fatigue. And usually the mild and moderate TBI patients will be in the older age groups. So these hyponatremia, memory problems, and fatigue are more in the older adult age group. Newer anti-seizure medications such as levetiracetam pose less risk. And another important thing to be noticed was that most of the patients were inappropriately discharged. That means they continued the anti-seizure medication even after the prophylactic period. So this also leads to prolonged and unnecessary anti-seizure medication usage, which may also inhibit the patient's recovery from the traumatic brain injury. So we comparing the two commonly used anti-seizure medications for post-traumatic seizure. One is phenytoin and levetiracetam. Phenytoin phenytoin is the drug which is most commonly used because it's cost effectiveness, but it causes hypersensitivity, phlebitis, hypotension, arrhythmias, and drug interaction. Levetiracetam is a newer drug which has a predictable pharmacokinetics and does not require any drug monitoring. So comparing these two, most of the centers go for the phenytoin because of the cost effectiveness. So moving on to the limitations of the study, because most of the studies were of a retrospective studies, there is a bias of seizure incidents. And out of the 6 studies were retrospective, and the 2 were prospective studies, but only one of the prospective study used a validated questionnaire. None of the studies included were randomized controlled trials, and this lack of randomized controlled trials also introduce a bias. So individual practitioner usually decide whether to prescribe a seizure prophylaxis or not, and this that means there's no randomization in that process. So this also introduces a bias, and so the choice of the drug, the duration of the drug, and all were based on the individualized judgment made by the practitioner. So that uh, is another reason for the bias. So these were the limitations of my study. So to do a detailed critical appraisal of the meta-analysis, I hand over to Dr. Keta.
Thank you, Kumar, for the lucid presentation. I will now take through the I'll now take you through the critical appraisal of this systematic review. So, we are aware that a lot of guidelines and healthcare decisions rely on systematic reviews as one of the key tools for achieving evidence based healthcare. So, uncritically accepting the results of a single systematic review can have certain risk. This is a popular and most ideal critical appraisal tool, which is called as Amster tool, which is a measurement tool to assess the systematic review, which is practical and easy to use and can be used by healthcare professional. It is rapid and has a reproducible assessment of the quality to conduct a systematic review. It has a 16 item checklist which contains both the critical as well as non critical questionnaires, and it helps, and it is quite detailed and comprehensive, and it will help us to distinguish high quality reviews. There are other tools also like the CASP questionnaire, but this is a better tool when it comes to a systematic review. So I'll take you through all the 16 questions, starting with first, which is a non-critical question, which is, did the research questions and inclusion criteria for the review include the components of PICO for this particular study? So the answer to this, I would say, is yes, because they have the authors have uh, defined what the P is, that is patients with mild or moderate traumatic brain injury. Their intervention is seizure prophylaxis in early post-traumatic seizure patients, and any anti-seizure medications can be provided for the same. And the control group did not receive. The outcome was any early incidence of post-traumatic seizure. The authors have not truly defined their type of study that they will be including in the research question and the inclusion criteria, but it has been further defined later during the literature search. So I would still say yes to this non-critical question. Going to the next question, which is, did the report of the review contain an explicit statement that the review methods were established prior to the conduct of the review, and did the report justify any significant deviation from the protocol? So any systematic review before it is conducted, it has to be written, the protocol has to be written in a detailed manner, and this protocol has to be written and registered on this Prospero website, which is the International Prospective Registry of Systematic Reviews. Like we register all our prospective studies for CTRI. For systematic reviews, it is Prospero, and it has any deviation from this written protocol has to be altered on this Prospero website, as well as it has to be mentioned in the publication. So yes, the authors did mention about registering their protocol on Prospero, and it was a well-written protocol before the study was initiated. The third non-critical question will be, did the review authors explain their selection of study design for inclusion in the review? So the answer to this also will be yes. Sri Kumar just went through the whole Prisma flow diagram, and we can see here how they have screened the titles and the abstracts as well as the full text, and further also excluded, they have given reasons for inclusion and exclusion of studies. They have specifically mentioned why the highest quality of studies, that is the randomized clinical trials, were not included, because they did not encounter it. Plus, it might be not practical to do a randomized clinical trial, according to the authors, because of a small effect size, that is about 0.6%, and small risk of early post-traumatic seizure, that's only 4 to 8%, and a poor follow-up. And hence, it might be not practical to do a large randomized clinical trial, and hence the reason for its exclusion. The fourth critical question will be, did the review authors use a comprehensive literature research strategy? So for this critical question, I'm afraid the answer will be no. I will tell you the reason why. In the text mentioned, they have mentioned that the authors have screened PubMed, Google Scholar, Web of Science for relevant articles with the important mesh terms. When it comes to searching for the review articles, it is important to also search all available clinical databases. The largest and the most complete database, that is Cochrane, was not included. And also Embase, which has a better coverage of European and non-English articles, was also not covered. Also, the authors have mentioned that only English articles were mentioned. That again decreases the quality of the systematic review, and hence the answer to this will be no. The fifth question will be, did the review authors perform a study selection and duplicate? As Sri Kumar already mentioned, 2 investigators had screened the abstracts and titles, and 3 reviewers had gone through the detailed full text, and they were blinded, and hence the answer to this will be yes. On a similar line, the sixth question, did the review authors perform a data extraction and duplicate? The answer to this also will be yes. Going to the seventh critical question, did the review authors provide a list of excluded studies and justify the exclusion? So the answer to this would be a partial yes. Uh, the authors have provided their reasons of excluding certain studies and the abstracts, the reason being the studies being a narrative study, or GCS data not reported, or the mild and moderate TBI not being separated from severe TBI, early PTS outcome data not reported. So there are various reasons given, and they have given reasons for why the studies were excluded. But ideally, these studies should be extended and accounted for in detail fully by the review authors in a tabular format according to the Cochrane Handbook for Systematic Review. Since as they are reviewed by multiple readers, and there is a risk that they may remain invisible. So they have provided a reason, but according to the Cochrane Handbook, it should be explained in detail, and the reason should be given in detail why the study was not included. And also the methodology and the other variables need to be mentioned why the exclusion, why the studies were excluded. So the answer to this will be a partial yes. Now, coming to the eighth question, that did the review authors describe included studies in adequate detail? I would say yes. The studies have been described in adequate detail with the type of study, the severity, the total mild with moderate traumatic brain injury incidents, the anti-epileptic drugs used, how many patients were given seizure prophylaxis versus how many were not given, and what was the incidence of seizure in both. It would have been more. It would have been a really useful point to include how many patients were given what dose of drugs, to really see if the dose is making a difference. And secondly, it would have been also good to know whether how many times a seizure occurred in a particular patient. But they had not defined this in their objective. So, and they have explained what they had planned to do, and they have described it in a adequate manner. In not only this table, but also a supplementary table is also available for the same. So the answer to this will be yes. Now, did the review authors use a satisfactory technique for assessing the risk of bias in individual studies that were included in the review? There can be bias at various stages while designing, while conducting the systematic review, while screening the articles, while doing a literature search. So a risk of bias tool is very important when it comes to systematic review, critical appraisal, and for a non-randomized critical study, the risk of bias tools are different. One is Robin's tool, the other is New Ottawa Scale tool. So this particular study had used the New Ottawa Scale tool, the NOS tool, to do the risk of bias study. The suggested overall risk judgment for a randomized critical trial is the ROB 2.0, which is more detailed and more comprehensive. But since this study had included only non-randomized studies, and that is all retrospective as well as or majority were retrospective with one prospective study, to be more precise. So hence they did not use this particular risk of bias. But yes, they have used NOS, and hence the answer to this also will be yes. Now, coming to the 10th question, did the review authors report on the sources of funding for studies included in the review? Since this can also lead to a bias, and yes, it has been well reported in the conflict of interest disclosure. And then coming to the other critical question is, if meta-analysis was performed, did the review authors use appropriate methods for statistical combination of results? And this is a critical question, and the answer will be in yes, no, or no meta-analysis conducted. So the answer to this will be yes, since the meta-analysis was conducted, and they have used to study the outcome measures in a meta-analysis, either odds ratio or RR or absolute risk reduction is used with 95% confidence interval. So this particular study had used absolute risk reduction, and they have given an explanation of why ARR was used, and it has been mentioned in their literature. Apart from that, the meta-analysis results were also in detail explained. So the answer to this will be yes. Coming to the next question is, if meta-analysis was performed, did the review authors assess the potential impact of risk of bias in individual studies on the results of the meta-analysis or evidence synthesis? And the answer to this will be yes. The Newcastle-Ottawa scale has been used, and the risk of bias has been studied, and any biases which have and the biases have been rated according to the selection, comparability, and the outcome scoring, and total points are given. And any points ranging between 7 to 9 are considered as good, 5 to 7 are considered as fair, and 0 to 2 is considered as poor. So this is a validated tool, and it has been studied by them, and the risk of bias of individual studies have also been studied and reported. So the answer to this will be yes. Coming to the next question, did the review authors account for the risk of bias in primary studies when interpreting or discussing the results of the review? The answer will be yes, as the literature did mention about the risk, why the risk of bias, how the risk of bias was there because of some patients, as Sri Kumar discussed, that it had included patients in rehab of hospital, and there was a failure to provide adequate follow-up, and hence this explanation was given by the authors. Coming to the 14th question, did the review authors provide satisfactory explanation for and discussion of any heterogeneity? So it is important to study the heterogeneity between the different studies that are included in the systematic review, in order to see that if a meta-analysis can be done, and if the cumulative result that we are obtaining can be reliable or not. So it can be done with the help of I-square, or looking at the confidence interval, how it is, whether it is crossing one, things like that. So they have used the I-square statistics, and they have reported a heterogeneity of 4%, which is less. They have also included a negative Cochrane Q test, and has reported a low heterogeneity between the different studies. Coming to the 5th question, whether a quantitative synthesis was done, and an adequate investigation of a publication bias was done. So whenever a systematic review is done, publication bias needs to be ruled out, and a popular way to do it is by doing a funnel plot, by putting and seeing the symmetry of the study on both sides of the funnel plot. And for the funnel plot to be reliable, we need at least 10, ideally 10 studies, at least 10 studies, and ideally 20 studies. This particular systematic review had only 8 studies, but they have reported the funnel plot, and they have shown that there is a symmetry of funnel plot for both their primary as well as secondary outcome. So the reporting has been done, though it's not the most ideal way to do it, since we need, the recommendation is to have at least 10 studies to really rely on the funnel plot to rule out a publication bias. But still they have done, and it is acceptable. So the answer to this will be yes. Now, did the review authors report any potential sources of conflict of interest? So, yes, it has been included at the end, and it has been also explained in detail. So the overall confidence needs to be calculated for the Amster 2 criteria for is for overall confidence, which divides it into high, moderate, low confidence, and critically low confidence. So this study belongs to a low confidence because there is one important critical weakness, that is poor literature search, which could have been more done in more detail and more exploratory manner. And though there were no other critical or non-critical weaknesses, but having one critical flaw can also lead to a low confidence in Amster 2 criteria. So, though the authors have reported that there is a moderate, very modest amount of decrease in risk reduction by giving seizure prophylaxis in the post-traumatic TBI patients in mild and moderate TBI, the overall take-home message will be practitioners should carefully weigh the prevalence and the risk of early seizures against the potential adverse events from anti-seizure medication. Though there is the BTF does not really state the does not recommend to give seizure prophylaxis for mild and moderate TPI. The overall practice is to give and it is there is to give seizure prophylaxis even for these group of patients. So it can be carefully reviewed for different patients and can be individualized. If there are certain risk factors, as Sri Kumar already stated, that positive head CT findings of subdural hematomas or traumatic SAH, or especially temporal lobe contusions, which can pose our patients with a very high risk of seizures in the post-traumatic period. These group of patients can be given some seizure prophylaxis, and a benign drug like levopril can be opted for these group of patients in case there is a risk or fear of having side effects with other potential anti-epileptic drugs. The first day of the trauma is the most common time for early post-traumatic seizure, as also stated in this review, and hence that should be targeted. Delaying treatment past the initial hospital entry may miss an opportunity for effective prophylaxis. This prophylaxis can be given only for the early post-traumatic phase period. So that is 7 days and may not be continued for a longer time after that. If the patient does not have any risk factor, the patient does not have any seizures prior to the trauma. Thank you.
Thank you, Dr. Srikumar, and thank you, Dr. Keta, for that wonderful presentation and discussion. So we have one comment from in the text box as to there is a reason to give prophylactic AED to all patients with TBI irrespective of severity. So do you agree to that? Because in our practice, as what we do that. So what is your
Yes.
take on that?
So we also in our institute also there is a tendency to give seizure prophylaxis in the post-traumatic period, irrespective of it being mild, moderate, or severe, because uh, as already stated, there are certain risk factors, and the pathophysiology also states that there can be a high risk of seizure in the post-trauma period, and to just to give an example of a practical difficulty, if we see a patient who is probably dropping a score, we can feel that we may wonder whether it's a seizure that the patient is having, or is it the cerebral edema, or is there a worsening in the traumatic brain injury. So all those problems are there. So if the patient is given some form of prophylactic anti-epileptics, and our institute also we do give seizure prophylaxis for post-trauma patients if the CT scan finding is showing a traumatic brain injury.
Yeah, and also the fact that the only thing which we can do is to prevent secondary brain injury, and
Secondary brain
this is one
damage.
of
Yeah,
the most important and preventable cause of
yeah,
secondary brain
preventable.
injury. So
Correct.
we are more
Yeah,
liberal in giving anti-epileptics, and like in the exclusion criteria, the meta-analysis did not include low and middle income countries, where still there is a challenge on the resource availability to kind of screen these
correct.
patients or have
Yeah,
better neuromonitoring facilities to kind of pick up seizures. So we would probably be doing more good by being
yeah,
more liberal with our seizure
correct.
prophylaxis.
Yes, yes,
Yeah.
yes.
So thank
I
you
agree
once
to
again
that.
on behalf of Neurocritical Care Society of India and Classroom Series. We would love to have you once again on these forums. Thank you very much, Dr. Srikumar and Dr. Keta.
Thank you so much, Matangi. Thank you, NCS.